So I'm not going to really go over this, but we all know about the benefits of exercise. We've known about the benefits of exercise for hundreds of years, even from ancient times, and it was obviously a therapy that was used quite a lot. But it wasn't really until 1995 that the real first exercise guidelines were published by the American College of Sports Medicine in the US, really advocating for the role of exercise for health in all Americans. And as many of you know, the ACSM Centers for Disease Control guidelines are for everybody to be doing at least 150 minutes of moderate intensity exercise on a weekly basis. And of course, all of us in this room are meeting those guidelines, of course. But it wasn't really until 2002 that the American Cancer Society recommended exercise for the prevention of certain forms of cancer. And many of you will know, if you're regularly physically active at the guideline, so that's 150 minutes, that's associated with a reduction in the risk of breast cancer anywhere from 30 to 40%, colorectal cancer, 40 to 50%. This evidence has been around for a little bit, and most of this evidence is based on observational data. There's no randomized data yet looking at an exercise prescription or exercise training intervention. Are you still hearing me okay? Yeah. Okay. Looking at an exercise training intervention on the prevention of certain forms of cancer. So, but my work concentrates primarily on exercise following the cancer diagnosis. And this is an area which has been relatively understudied relative to the role of exercise in other clinical diagnosis. And this is where I'm going to concentrate my talk on for the next 45 minutes or so. So as we all know in this room, we've had significant improvements in cancer survival over the past 40 years or so. And so just in the US alone, just over the past, since the early 1990s, the death rate from cancer has dropped 18% in a pretty short space of time. In the US, we have now 13 million cancer survivors, and this figure has exploded from just 3 million in the early 1970s, and this figure is expected to double over the next 2 decades. We've got a rapidly aging population, of course, so the incidence of cancer, as you know, is primarily over individuals over the age of 65, so it's going to have a huge segment of cancer survivors that are now living longer and longer from their cancer diagnosis. And of course, this is great news. Of course, it's great news. But as these cancer patients are living longer and longer, we're now seeing the acute and late effects of treatment that they're getting for cancer. So they're treated with cancer, surviving their cancer, but now we're seeing the side effects of the treatments that they've been receiving. And so it's been quite interesting how survivorship, that's a term that's used a lot in the US, survivorship has really exploded over the past decade or so, and exercise as part of survivorship is really exploded with. So can we use exercise as a vehicle, as a model, to actually can we control some of the acute and chronic side effects of cancer and cancer therapy? So with this field, this is just a schematic here, a very simple one that shows that the number of studies published in the area of exercise and cancer over the past few years or so. So the first study was published in 1988 by Mary Vicker. This showed Mary Vicker was a nurse and was very interested to look at the role of exercise training in early stage breast cancer patients going on to adjuvant chemotherapy. And looking at really exercise training to control fatigue levels. So she was noticing that a lot of cancer patients go through adjuvant chemotherapy, become fatigued, and wanted to look at the role of exercise to see if it could mitigate that fatigue. So that was the first study that was published in 1988. And you can see it wasn't really many studies, just 1 to 2 studies a year over the next decade. In 2001, Roanne Siegel, who was a medical oncologist in Canada, in Ottawa, published the first randomized controlled trial of exercise training. Again, this was in women with early stage breast cancer undergoing chemotherapy. It was published in the Journal of Clinical Oncology, and as we know, that's a flagship journal for ASCO. So it was a pretty big deal for exercise people such as myself to show that we're publishing in journals like JCO. So that was a big landmark in showing that really exercise has kind of arrived on the scene. The American Cancer Society in 2003 published the first exercise guidelines for cancer patients. Now this wasn't really based on much evidence, but it was really the first kind of statement from an official organization like the ACS to say that individuals should be exercising following a cancer diagnosis. And this was published in CA Cancer Journal for Clinicians, another big publication. So that again, it was another publication that put us on the road. In 2005, Michelle Jones published the first study looking at the relationship between exercise behavior and survival in women diagnosed with early-stage breast cancer. This was not randomized data, this was observational data, and I'll talk a little bit more about this data later, but this was published in JAMA, again, and now it was showing that exercise might be beneficial just beyond managing the side effects in certain toxicities from cancer and cancer therapy, but also might be associated with recurrence in early-stage breast cancer patients. Kerry Koenig, who was my ex-supervisor in Edmonton, Canada, he's now got an ongoing study. I don't know if you're recruiting here actually for this. It's called the Challenge Trial. It's in colorectal cancer patients. It's a trial of about 1,000 colorectal cancer survivors looking at the impact of a randomized controlled trial, phase 3, with the primary outcome of disease-free survival. So this trial is ongoing right now. It's recruiting in both Canada and in Australia. And so I think they want 1,000 patients. I think they're about 200 patients in. So Kerry published the methods for this paper in 2008, but the primary results from that trial won't be available for a few years yet. And then Jeff Meyerhoff from Dana-Farber published a really nice paper that I'm actually not going to talk about today, but was really so Jeff published some epidemiologic evidence looking at the relationship between exercise and cancer-specific mortality in individuals diagnosed with colorectal cancer. And Jeff published a number of studies in the JCR looking at this relationship. He then published another paper in JAMA that showed that the relationship between exercise and colorectal cancer response to exercise might differ as a function of molecular features of tumors. So now we're getting to a little bit more sophisticated, showing that it's not just one size fits all. Not all tumors are going to respond to exercise, but it actually might depend on molecular features of tumors and their response to exercise. Just like you would maybe with radiotherapy or with chemotherapy or targeted therapies, exercise won't just work for everything. Maybe it'll depend on the molecular features of the tumor. So that just gives you a sense of where the field has kind of come from and where it's moving to. And so the next, in my talk, I'll just talk a little bit about some of this data and go into a little bit more detail. So just very simply, I'm just going to use a schematic to use it as a framework for the rest of my presentation, right? And really how we can use and think about the application of exercise across the cancer continuum. So of course we have diagnosis, and we have a period of time of what I would call a window of opportunity, and before patients go for surgery. Most patients then will go into some form of adjuvant therapy. Obviously this is very simple, and then you get into the survivorship post-therapy phases. So you can think about the role and application of exercise across these different phases, if you will. So we can think about exercise training in the pre-surgical setting. Can we use exercise training here to lower surgical complications? Can we improve post-op recovery time? Can we improve the time from surgery to initiation of adjuvant therapy? We know that the time from surgery to initiation of adjuvant therapy is associated with prognosis. So can we shorten that time and get patients to therapy quicker? We can think about the application of exercise during adjuvant therapy. So within this context, most of this work has been looking at exercise to control treatment-related side effects. Can you control fatigue, nausea, pain, exercise intolerance with an exercise therapy intervention during adjuvant therapy? The other way you can think about exercise in this context is, can we use exercise actually to improve therapeutic response to conventional or forthcoming therapies? And then finally, you can think about exercise in the post-therapy setting, and this could be used then to treat or prevent kind of the late effects, the cardiovascular late effects of cancer and cancer therapy, or even to improve overall survival in cancer survivors. So first I'm going to talk a little bit about pre-surgical setting and what evidence we have there. So we just recently reviewed all the evidence actually in the field to date, and it is what it is. There's not really many studies actually in the pre-surgical setting. We only found 5 studies that have looked at the role of exercise prior to surgical resection. And you can imagine these studies are pretty difficult to do because you have a really short window of time, particularly in the US, where if you get diagnosed, you typically get surgery within a week. But when I did some work in Canada, particularly a longer period of time in which we can intervene. So there's very limited evidence in this setting, but the evidence that we do have would suggest that exercise is feasible and safe within this period prior to surgical resection. So we did one of these studies when I was doing my PhD in Canada, and this was in patients who were surgical candidates with non-small cell lung cancer. So this was a very simple study. We just did 20 patients because it was really a proof of concept study to see if we could actually recruit, train patients within this setting. We measured their peak oxygen consumption. This is a peak VO2 test to measure that, which is a gold standard assessment of their cardiorespiratory fitness or their exercise tolerance. We then trained these individuals for 4 weeks prior to surgery. So the average age of this population was 72, all of which was sedentary, right at diagnosis, and we trained them 5 days a week. We trained them 5 days a week at anywhere between 60 to 100% of their baseline fitness. We basically trained these lung cancer survivors like athletes. So just within 4 weeks of training, we improved their fitness levels by 18%, just in 4 weeks of exercise. So that's what we did with 4 weeks of exercise. We also measured their fitness levels 30 days after surgery. And what we found is, not surprisingly, after the completion of surgery, their fitness declined by about 15%. But we know that, of course, if they hadn't done that exercise training intervention before, they would have this decline of 15%. So I think from a physiologic perspective, we've almost made the surgery disappear from a physiologic perspective. Now, we didn't have a control group in this study, unfortunately, because it was just a single-arm design. But I think it does demonstrate that you can do these short, intensive exercise training interventions. You can get significant improvements in exercise tolerance. Now, whether that's related to improvements in post-op recovery and surgical complications, we don't know because we haven't done that study. When I went down to Duke, we wanted to do the randomized trial, but as I said, we have only a week from diagnosis to surgery. We're pretty aggressive, but I don't know if we could be that aggressive and have that much of an impact. It's been very interesting to when we first got into this field, because most of the work has occurred in the survivorship setting, because a lot of the opinions have been you really can't exercise people during adjuvant chemotherapy or radiotherapy. It's too toxic, you can't exercise these people. And when we first spoke to our medical oncologist colleagues, they thought we're actually going to kill patients if we exercise them during adjuvant chemotherapy. But I'm pleased to say we've debunked some of those myths. So there was a review by Rebecca Speck, it was published a couple of years ago, and about 40% of all exercise oncology studies have been published during therapy. So to date, we have about 80 to 85 studies that have looked at the role of an exercise training intervention in patients diagnosed with cancer. Now that might sound like a lot. If you look at the role of exercise in cardiac disease, it's about 3,500 studies. So we've got a long way to go. Most of this work is in patients with early stage disease, and about 80% of these 40% is in women with early stage breast cancer. That's where a lot of the money has been, and that's where a lot of the researchers tend to follow the money, as you know, so that's where a lot of the research has been. So look, most of these studies have tested what I consider to be traditional exercise prescriptions. This would be exercise training individuals 3 days a week. Typically it's endurance type training. Typically the exercise interventions are anywhere from 12 to 15 weeks in duration, and they're at this moderate intensity exercise. It's a classic kind of exercise prescription that you see in a lot of clinical populations. And I've just pointed out here that we don't actually know what the optimal dose or type or intensity of exercise is to improve outcomes in patients undergoing adjuvant chemotherapy. What I'm pleased to report, the data does suggest that exercise within this context is feasible and safe, and it's also efficacious on improving a number of select outcomes, including things like quality of life, fatigue, exercise tolerance, pain, nausea. But there's considerable heterogeneity in this evidence base. So I'm just going to talk you through just a couple of example studies just to give you a flavor of what some of these studies have looked like. So this is data again from Kerry Kearney. It was published in the JCO in 2007. This was a randomized controlled trial, 242 early stage breast cancer patients going on to conventional chemotherapy. So what Kerry did, he did a baseline cardiopulmonary exercise test in these women, as well as a bunch of other outcomes, and then randomized these women to one of three conditions. They either got a supervised aerobic training group only, that was 78. The aerobic training group trained for 3 days a week. It's 60 to 75% of their baseline fitness, so this is again, it's a moderate intensity exercise training program. And the adherence level, so the amount of time that the women actually turned up to the exercise sessions, was 70%, which actually is not too bad at all. The classic figures in cardiac rehab is that 50% dropout within the first 6 weeks. So the fact that you can get these women to attend 70% of sessions during adjuvant chemotherapy, I think is pretty good. In the second group, they looked at progressive resistance training, 82 patients. Again, this is 3 days a week, 60 to 75% of one repetition max of their maximum strength. The adherence in this group was 72%, and then the third group was new care and no intervention control. And the average length of exercise training was 17 weeks. So this is the fitness data here. So this is cardiopulmonary fitness, VO2 peak. I'll just mention that VO2 peak typically in humans ranges from 10, which is somebody with heart failure, all the way up to somebody like Lance Armstrong when he was riding, plus minus supplementation. Assistance, yeah, we'll call it assistance. Yes, we'll be up to somewhere like 85, his VO2 would be at 85. That guy's just a heart, pair of lungs, and pair of legs. Osmia mortals kind of exist somewhere in between. Just to put this into context, if you have a history of heart failure, you have VO2 slips below 15, you're eligible for a transplant. So our breast cancer patients are not too much above that 15 threshold, actually. So this is the control group, this is baseline, this is post-intervention, aerobic training and resistance training. And I think quite importantly, what you see in the control group, this is a group that didn't get any exercise training whatsoever. You see this 5% decline in fitness levels over just 17 weeks of chemotherapy. Now again, to put this into context, typically you see a 10% decline in your fitness every decade. You see it here, you see half that decade of aging in just 17 weeks of chemotherapy. We've actually got data from our group in women getting AC chemotherapy, showing they get a 10% decline in just 12 weeks of chemotherapy. So it's almost like chemotherapy is a model of accelerated physiologic aging. So I think that's just important. I think the data from the control group is almost as important as the data from the exercise group. So what happens with aerobic training? Well, the aerobic training completely mitigates that decline that you see in the control group. I know a lot of times we're looking for improvements in fitness with aerobic training, but I think just showing here that we mitigate the declines in fitness in the control group is very important, and I think it's a favourable impact. In terms of resistance training, you can see that resistance training does not mitigate the decline that we see in fitness during chemotherapy. So I think, and many of you will know, typically resistance training does not improve cardiorespiratory fitness, improves muscle strength. So you probably will guess that this would be the case. But the message from this study, at least, is if you want to improve or maintain fitness during adjuvant chemotherapy, aerobic training is the way to go. This is another study here, not just to say it's all about, breast cancer. This was published again by Rowan Seal in the JCO. And this was a trial in men with prostate cancer receiving androgen deprivation therapy plus minus radiation therapy. And so what Rowan did in this study, again, she had a control group, she had an aerobic training group and a resistant training group, very similar to the design of Kearney's study. I think the intervention length here was 6 months. Again, you see this decline. This is again VO2 peak. You see the decline in the control group. Aerobic training in this instance does not mitigate the effect of ADT and plus minus radiation therapy. You see this mitigation, but with resistance training, you actually see a slight improvement in fitness. And many of you will know with androgen deprivation therapy, you obviously have a lot of muscle atrophy from that. So you'd really anticipate that resistance training that improves muscle strength would actually translate then to an improvement in fitness. So I think this is really important. It's really getting to the specificity of exercise training, and depending on the population you're dealing with, and maybe also depending on what therapy they're getting, will obviously lead then to what kind of intervention that you should be giving to your individuals, depending on the scenario. So that's some data looking at the role of exercise to really control some of the side effects of therapy during adjuvant therapy, whether it be ADT or chemotherapy. Another way we can look at this as well is, can we look at exercise to improve therapeutic response? And that's obviously a very different application of exercise. And so I've got the arrow coming here because it's very hard, of course, to look at the effect of exercise on improving therapeutic outcomes in the adjuvant setting because there's not really anything to image. You know, there's micrometastatic disease, but the primary tumor has been removed, of course, from surgical resection. So we've been looking at the neoadjuvant setting, where obviously the tumor still exists, and so you can do some imaging to see what's happening to tumor biology. So if you look at therapeutic response, there really hasn't been much data on this whatsoever. This is, we're going to talk later in the workshop hopefully, but I think this is one area of opportunity that I think is just ripe for the picking. So there's actually only been one preclinical study that's looked at the role of exercise plus minus doxorubicin. This was actually a mouse study that we did a few years ago. But to be honest, it wasn't that good. So I'm not really going to talk about that study so much. But it was an idea we had a long time ago. We got published, but I think we've come a long way since then. In Kerry's clinical trial, his 2007 JCO paper, he did find that resistance training improved treatment completion rates. And that's the only study that we have showing that resistance training can improve treatment completion rates. He just published another paper in the JNCI just a couple of weeks ago and found no effect of aerobic or resistance training on improvement of completion rates in patients, again, with early-stage breast cancer getting adjuvant therapy. So I think, Jeff and I were talking about this on the way over, and I think it's something a lot we talk about. It improves their ability to get through therapy, but actually there's very limited evidence to support that statement. So we've been working a little bit in this area. I'm just going to share some data with you. So many of you know we've got a lot of radiation oncologists in the room, and we obviously got a lot of people who know a lot about cancer in the room. And you know that solid tumors have very abnormal vasculatures. They're very leaky, they're very inefficient. So you can see just by this picture right here, the blood vessels are marked in red. You can see they're very leaky, they're very tortuous. They're not very good at really delivering oxygen and nutrients into the tumors. And as a result of that, of course, you get areas of hypoxia. And we know that hypoxia, of course, is a significant driver of not only aggressive behavior, but also therapeutic resistance, particularly to things like chemotherapy and radiotherapy. So chemotherapy is delivered, of course, through the blood system, so you get accumulation of chemotherapy by the blood vessels, but it really doesn't penetrate these hypoxic regions. And as we all know, this is a significant issue that we have in oncology. So we've been interested to look at the role of exercise to see if it can modulate hypoxia levels in tumors. So we did a very simple study. This was in an orthotopic model of murine breast cancer. It was in an R-negative model. It was 4T1. So we took biopsy mice. We did an orthotopic injection of 4T1. We then waited 3 days for the tumors to establish. We then randomized the animals either to a voluntary wheel group or to a sedentary control group. So just to let you know, if you put a female mouse in a cage with a wheel, you turn the lights off, they'll run anywhere between 4 to 7 kilometers a night. Mice love to run. It's great. They're fairly patient, that's what they say. So what we can do, of course, we can measure tumors, caliper measurements. And so when the tumor got to 1.5 centimeters, we sacrifice the animals. So firstly important, what's the impact on tumor growth rates? Well, this is tumor volume, this is days, this is just 18 days of exercise. Gray line represents the control group, the blue line represents the exercise group, and what you see is a 30% reduction in tumor growth rates in mice that have availability of running wheels relative to sedentary controls. So this is important right off the bat, showing that just exercise alone, this is not exercise with chemotherapy, this is not exercise with some magic components in the food, this is just straight up exercise. And it's inhibited tumor growth around about 30%. So what we did there, we then took the tumors out and we said, okay, what's the vasculature of these tumors looking like? So we did this by looking at CD31, and very interestingly, we found that exercise significantly improved macrovessel density in these tumors. You're probably sitting there saying, this is exactly what we don't want. You don't want exercise to improve blood flow to tumors. And so you see, we get, as you can see in this figure, it's very nicely denoted here, this paper is actually just submitted. So we see this increase in CD31. And so you get better microvessel density in exercise versus sedentary control. We also did some MR scans. So we've got a really nice 17 magnet back at Duke. So we can do MR scans, we can look at perfusion of tumors. So you can see a control tumor, it's pretty dull, doesn't really light up very much because there's not much blood flow. But you can see this quite nicely, of course, in the exercise group. These tumors light up like light bulbs, just significantly improving blood flow into tumors. Turns out, of course, if you've got ischemic heart disease or ischemic lung disease, exercise does exactly the same thing. Also works in tumors. But when you do that, when you improve blood flow into tumors, what happens? You reduce hypoxia. So we also looked at hypoxia through EF5, and we found a significant decrease in hypoxia levels in tumors that have been, well, in mice that have had tumors of exercise relative to control. So knowing this, we thought, well, if we know that hypoxia is a significant modulator of resistance, what if we combine exercise with chemotherapy? Can we improve chemotherapy delivery and maybe response rates? So this is what we did. So this, again, was in 4T1. It was the same design. What we have here, we have gray, which is the control group. The black line is chemotherapy only, the blue line is exercise only, and then the red line is exercise plus chemotherapy. And of course, what happens is the control group, the tumors grow the quickest. You add chemotherapy, and that's associated with tumor growth delay. Of course, we know that. This was actually cyclophosphamide. This 41 response to cyclophosphamide. So we know this is what we've shown before. Interestingly, if you do exercise alone, it's just as effective as chemotherapy at delaying tumor growth in these models. Now, I'm not saying we should throw out chemotherapy, I'm not saying that, but it's kind of interesting that we saw it in this particular study. But of course, the punchline is, if you combine exercise with chemotherapy, it's associated with the slower tumor growth. So this data is currently submitted, it hasn't been peer reviewed yet, so you can take this with a pinch of salt, but hopefully this data will be coming out soon. So now we thought, okay, well, we've got this data, can we now translate this to patients? So we just finished a very preliminary exploratory study where we've looked at this. So this was in 20 women with locally advanced breast cancer, unresected. So we got these patients right at diagnosis. We did a bunch of baseline assessments, and I'll go through some of those assessments. Then there was initiation of chemotherapy, and we did 12 weeks of exercise training during, this was AC times 4. And then we also did biopsy at baseline, we did biopsy of tumor biopsy prior to surgery, or if we went for additional neoadjuvant therapy. So patients either got randomized to 4 cycles of AC, that's 12 weeks of AC chemotherapy, or they got AC plus supervised aerobic training. So in this contest, our aerobic training prescription was 3 days a week, and we trained these women at 60 to 100% of their baseline fitness. So we did a little bit of interval training in women getting neoadjuvant chemotherapy, but they loved it. We trained these women really hard. The adherence rate in the study was 82%. So I think it's showing here that even during neoadjuvant chemotherapy, pretty intense neoadjuvant chemotherapy, women can come in, they can exercise, and really do quite well. And then in the study, we repeated the baseline assessments. So just to show, this is our fitness data from this trial, and this has just been published. So this is VO2 again. We have the control group, or chemotherapy alone, which is AC, or AC plus aerobic training. Again, just as Kerry saw, you see this decline with just getting chemotherapy only. In our context, we saw a 9% decline in fitness in just 12 weeks of chemotherapy. But if you exercise train during that 12 weeks, not only do you get complete mitigation of the decline you see with chemotherapy only, we actually see this really nice improvement in fitness over the course of 12 weeks. So I think the message here, if you tweak the exercise training program a little bit, you actually get really nice improvements in fitness. And if you actually look at the delta change of 4.1 mils, I think that's really clinically important, because we know that something like 3.5 mils difference in fitness in women is equivalent to about 70% difference in mortality. So I think so this data is important. Again, it kind of reiterates what Kerry found, but also shows that we can train these patients and improve fitness, and women get undergoing neoadjuvant chemotherapy. Now, we did take plasma in these patients, and we looked at circulating changes in a number of factors, and we took plasma and serum at 0, 3, 6, 9, and 12 weeks. And what we measured in these patients, we had some data from another study showing that exercise might impact circulating endothelial progenitor cells. These are the cells that are released from the bone marrow, have been shown to be important for things like tumor neovascularization, but also important for recovery and injury repair. So what you have is the grey line, which is exercise plus AC chemotherapy, and then the black line represents AC chemotherapy alone. And so with AC chemotherapy, you see this significant decline in circulating levels of these endothelial progenitor cells over the course of therapy. But with exercise, you see this significant improvement in circulating levels. And this is kind of interesting because there's a lot of data coming out, particularly from David Leiden's group at Cornell in New York, suggesting that these circulating endothelial progenitor cells are released from the bone marrow and can actually form the pre-metastatic niche and things like the lung, and actually can prepare tumor cells to metastasize. So you think that release of progenitor cells in this context actually might be a bad thing. We actually don't know from the study because we weren't able to measure things like recurrence and things like this. The study obviously wasn't big enough, but it is interesting we have this different set of data, if you will. We also measured a couple of circulating angiogenic factors, and in general we saw a significant decrease in these circulating factors during chemotherapy in the exercise group relative to chemotherapy alone. Now we did try, to do some imaging in the study as well. We tried to get some PET imaging to see if we could also look at blood flow into tumors from an exercise condition. So we have the exercise group and we have the control group. Unfortunately, it didn't work out quite as well as we wanted to. Very often, patients weren't able to get in for a baseline scan because the scanner broke down, or they'd run out of. You guys understand what I probably went through with this. It was very frustrating. So we did have some data in the AC plus exercise group, and we see this. In general, we see there's a little bit of a decrease, but we really don't know what to make of that because it's such a small number of patients. We also did tumor gene expression as well, and we did see modulation of a number of genes, and when we did pathway analysis, we found modulation of 57 pathways that were significant. Again, what these mean, we don't really know. This was fairly exploratory, but I think it's kind of an interesting model to use where we can now move forward and hopefully do a better job of this study moving forward, and that's what we plan to do when we move to tomorrow. So just finally, in the post-adjuvant therapy, and here we look at exercise to treat and prevent kind of the cardiovascular late effects of therapy. This is where most of the studies have been performed. Again, it's dominated by patients with early stage disease, particularly women with breast cancer. Again, these studies are typically following traditional exercise prescription guidelines, and the data is reported shows that exercise is safe and feasible and efficacious on a number of different outcomes. But again, I would just say there's considerable heterogeneity within these studies. I'll just give you a flavor of just some of the studies which have been done in this space. This is again Kerry Kearney's work, who's really one of the first randomized controlled trials in exercise training in following the completion of primary therapy. It was in 53 women with early stage breast cancer. The intervention was stationary cyclodometry. This was all supervised exercise training. It was a moderate intensity exercise training program. Each session was anywhere between 20 to 45 minutes in duration, 3 days a week for 15 weeks. I'll just point out that the adherence rate in this study was 98%. These women just didn't miss. So what's the data? The control group, this is baseline, this is post-intervention. Really saw no change in the control group. You wouldn't expect to be much change because these women weren't receiving any therapy. But with aerobic training, there's 17% improvement in fitness over 15 weeks of training. Our intervention was cyclodometry again. Again, we did a little bit of interval training in these patients and pushed them a little bit harder. 3 days a week for 14 weeks, the adherence rate was 85%. Median age of this group, I think, was about 74. This was a single-arm design. I'll just put these, you probably think it's pretty obvious, I'll put these on the same scale, just so you can appreciate the baseline fitness of our lung cancer survivors was 15.7. Again, 0.7 above that threshold that you'd be eligible for a transplant if you had a history of cardiac failure. But in this context, 14 weeks of training was associated with about 10% improvement in fitness. This wasn't quite significant. We got a small sample size. But it does show that we can train patients also with non-small cell lung cancer. So based on this early data now, we've got a number of trials on the go at Duke. I'm not going to go through all these in detail in the interest of time. We've got the study called Longevity. This is now looking at the optimal type of exercise training to improve fitness in early stage lung cancer patients. It's a 4-arm randomized controlled trial. The patients get randomized either to aerobic training alone, resistance alone, the combination or control. We're 100 patients in, so it's going quite well. EXCITE, of course you have to have nice acronyms for these trials, is 174 early stage breast cancer patients. In this trial we're looking at the optimal intensity of exercise training. It's a 3-arm randomized controlled trial, 16 weeks, 105 patients have currently been randomized. We just finished a prostate cancer study that looked at the role of exercise training immediately following prostatectomy for men with clinical localized prostate cancer. This was 50 men, it was a 6-month exercise training intervention. It was a 2-arm randomized controlled trial. I'm pleased to report it actually just got accepted yesterday to European Urology. So that should be coming up pretty soon. And then we have another trial that just started, and we call this our optimal timing study. We haven't really come up with a fancy acronym yet. In this study, this is going to be 160 patients newly diagnosed early stage breast cancer going on to adjuvant chemotherapy. this is a 4-arm randomized controlled trial where we're going to be looking at the role of exercise either during chemotherapy or following the completion of chemotherapy. So we're only 15 patients in, we've got a long way to go, but hopefully we'll get there eventually. In our trials, we measure a lot of different endpoints. We try and phenotype our patients as much as we possibly can. We're obviously very interested in cardiopulmonary function. We also get a measure of organ components that contribute or are determinants of exercise tolerance. So we look at cardiac function, we do rest and stress echo, we do spirometry, we look at vascular function, particularly endothelial function, which is fluid-mediated dilatation of brachial artery. We get muscle biopsies in our patients who consent to that because we're very interested in looking at muscle phenotype. And then we also get a lot of plasma, serum, we get patch geometry on our patients, we get OGTTs, and we also get a lot of patient-reported outcomes, including quality of life, fatigue, pain, and sleep quality. So just to finish off a little bit, I'm going to talk about a slightly different application of exercise as well. And this is something else you can think about in the context of post-therapy setting. So there's been a number of studies now looking at the association. I mentioned Michelle Holmes' paper at the beginning of my talk. They've looked at the association between self-reported physical activity and cancer-specific mortality in early-stage patients. So this is a forest plot here denoting the data that we have so far. So anything to the right of the line depicts higher mortality with higher levels of exercise. Anything to the left suggests low mortality with higher levels of exercise. The good news, of course, is there's nothing you can see to the right of this line suggesting that if you exercise more, that's not detrimental. You don't die quicker, which we obviously don't want. So the red dots represent here, the red squares represent the studies in breast cancer. The red square represents the average risk reduction in a particular study. The black line represents the 95% confidence interval. And you can see we have quite a spread of data. Where on average is depicted by the blue diamond, there's about a 35% reduction in the risk of dying from breast cancer in women who are regularly physically active relative to those who are sedentary. This is after controlling things like body mass index, stage of disease, and also treatment. So this is the independent association of exercise with cancer-specific mortality. There's also been some data in colorectal cancer. This is Jeff Meyerhardt's work from Dana-Farber, who found a 60% reduction in colorectal cancer-specific mortality in those individuals who are exercising relative to those who are sedentary. And I'll just mention here, which is quite interesting, is the actual dose of exercise that in colorectal cancer relative to breast cancer was double the amount. In breast cancer, it's about 150 minutes. In colorectal cancer, it's about 300 minutes. So suggesting that you might need a different dose of exercise to get the same magnitude of benefit across disease sites. In prostate cancer, this is June Chan's work at University of California, San Francisco. Again, men with localized prostate cancer, and found about a 50% reduction in those men reporting vigorous exercise relative to those men who are sedentary. So I would say that in general, I think there's a signal here. Obviously, we need a lot more data. This is very, very early days. But I think there is something going on here with exercise on recurrence following an early stage diagnosis. So what's going on? So why would exercise be associated with reduction in tumor growth rates or recurrence or metastases? Well, as we all know, when you exercise, you get modulation of a number of different pathways in peripheral blood. We know that, of course, exercise is very powerful for controlling metabolism. That's why it's an effective therapy for type 2 diabetics, but it also can impact oxidative balance, immune surveillance, inflammation and cytokines, and also levels of sex hormones. And of course, when you exercise, you get modulation of these pathways all at the same time. That's why it's such a beautiful intervention. And I think what happens here, you're basically changing fundamental growth factor availability, if you will, both in the primary microenvironment, tumor microenvironment, as well in the microenvironment of distant organs where cancer cells might metastasize or already might be laying dormant. And so what we're trying to do is really trying to understand what might be going on, both at the level of the host, as well as what might be happening in the tumor themselves. So I'm just going to finish off with a little study that we've just submitted, actually we just finished. So this was a study we did a few years ago where we looked at an exercise training intervention in 44 patients with solid tumors. And all these patients at the time had mild to moderate anemia. So what we did some baseline assessments in these patients, and then the control condition is they got randomized to darbepoetin alpha. So this is a few years ago when patients become anemic, they got EPO. Obviously that doesn't really occur anymore. So, this trial was done at that time. Well, the exercise group got EPO plus exercise training, maybe just like athletes do. Well, some athletes do. So, again, this was stationary bike, so we trained these patients on a bike, we did some interval training, 60 to 100% of their VO2 for 12 weeks. And I'll just report we improved VO2 relative to the control group. So, if you just take EPO alone, your fitness will improve about 5% over 12 weeks. If you do exercise training at the same time, that will improve about 25%. So those athletes really know what they're doing. They've got good chemists. So what we did in this study, we did 44 paired pre-post blood samples, and we tried to characterize the different host pathways. So we did leukocyte function to look at immune phenotype. We did metabolomics to look at over 50 different metabolic intermediates. And then we also did multiplex ELISA to look at over 35 different cytokines. Now I'll report that we didn't really see anything in terms of immune function and metabolism. In this particular study, we saw really no changes whatsoever. But we did see some changes in certain select cytokines. And these are the cytokines that are denoted by red that we saw significant reductions with exercise training relative to increases or just stable values in the control group. And these were hepatocyte growth factors, HGF, IL-4, MIT-1 beta, VEGF, which has received a lot of attention, of course, in patients getting anti-angiogenic therapy, and also TNF-alpha. So significant reduction in circulating levels of these cytokines in patients who have been exposed to exercise. So what we did then, we said, well, okay, what does that mean? If you do see reductions in these circulating levels, what does that mean in terms of tumor biology? So we took a novel approach where we tried to go in vitro to see what impact these changes in the cytokine levels in plasma, or in serum in this case, might have on tumor biology. So to go in vitro, it's very hard to mimic exercise in a dish, of course. You can't shape the dish more vigorously or something like that. So what we thought we could do, we could take serum from individuals who have been exposed to exercise relative to individuals who have been exposed to control. So we've got exercise-conditioned serum versus control-conditioned serum. And what we did, we placed this serum, that's not working very well. We placed this serum on human breast cancer cells, either ER-positive breast cancer cells, so MCF7, or MBA, MB231s, which are ER-negative cells. And then we looked at apoptosis, proliferation, and migration. So we're just basically exposing these cancer cells to serum either from exercise patients or control patients. So this is just the apoptosis data. I'm not going to go through all this data. So this is just serum from 20 breast cancer patients. So we didn't take blood from lung cancer patients and put it onto breast cancer cells. This is just breast cancer patients. This is MCF7, this is the 231s, the ER negatives. Blue represents exercise, gray is control. And what you can see right away, over 4 to 6 days, you get a significant increase in apoptosis in cells that are exposed to serum from exercise patients relative to serum from control patients. So basically, you put serum from exercise patients on these tumor cells and it kills the tumor cells. So that's a little bit of our data. So what's going on, where we're going next? So we just did a systematic review of all the trials that are listed in clinicaltrials.gov to try and get a sense of what the current wave or flavor of exercise oncology studies are. So only 5 of these studies are actually looking at pre-treatment exercise applications, so there's not much in the pre-surgical space at all. Again, most of these studies are either during therapy or post-therapy. They're typically looking at late effects. The sample size of these studies on average is 171 to date. The vast majority of these studies are still focusing on things like quality of life, fatigue, and physical function. So I think what are some of the future directions and gaps in this field? Well, pre-treatment, I think that's just wide open. It's just there for the taking. I think it's a very interesting setting in which to look. I think you can look at these window of opportunity studies, not just look at surgical complications, but you also can use that window of opportunity to maybe to look at some tumor biology studies as well. During treatment, a lot of studies have looked at, as I mentioned, patient-reported outcomes. I'm not saying that's not important, but I think we have enough data there now. I think what we can start looking at is some of the other understudied toxicities, such as cardiotoxicity, peripheral neuropathy, thrombosis, bone loss. These are really outcomes that we haven't looked at with an exercise intervention, but I think are very well indicated. In terms of efficacy, again, there's very few studies. I think there's just a little bit of our work, but nobody's really done a very good job of going in and really look at the interaction between exercise and can it potentially improve the efficacy of conventional forthcoming therapies. In terms of post-treatment and chronic and late effects, again, there's a lot of data there, but we really don't know mechanism of action. We don't really know why exercise is effective. In terms of recurrence, this is where we're doing a lot of our work. We don't know what the optimal dose of exercise is. We don't know what the right tumors are. We don't know what the right patients are. We don't have biomarkers. So as you can imagine, there's a lot of work to do there. And of course, there's also non-cancer related morbidity and mortality. A lot of cancer patients with early stage disease are going to die from cardiovascular disease, not from cancer. So an exercise is well indicated, of course, for cardiovascular disease. So I think there's some ripe opportunities there as well. So just to conclude, I think there's growing research and clinical interest in the role of exercise following a cancer diagnosis. I think the data to date suggests that exercise is safe, it's feasible, both to prevent maybe toxicity during therapy, as well as recover toxicity after the completion of therapy. I think some of the ongoing work is starting to address some of the fundamental questions, and particularly what's the optimal time, intensity, and timing of exercise training. But hopefully you can appreciate it's really just the tip of the iceberg. This field is just, again, right for the picking. So hopefully we'll have some interesting discussions this afternoon. And with that, I'll close and thank you for your attention.